G'day to everyone out there and welcome to another Rural Flying Doc presentation. My name's Dr. Jerry Considine and today we're going to be talking about haemochromatosis. Haemochromatosis is a progressive iron overload and it's a build-up of iron levels in the body, and often it's a silent disease, so people won't have hard and fast symptoms to describe it. It's characterised by an increased absorption of iron from the gut. And although we lose iron through the shedding of our skin, the gut mucosa and also blood loss, there's actually no active iron excretory mechanism in the body. So people end up absorbing 2 to 3 times the normal amount of iron, and that's through the hepcidin deficiency, which is the central iron homeostasis regulator. The main cause of morbidity and mortality of haemochromatosis is end-stage organ disease, involving the liver, brain, pancreas, and also the heart. Secondary haemochromatosis is caused by disorders of erythropoiesis and also the treatment of diseases with blood transfusions. A short note about genetics. It's the most common autosomal recessive genetic disorder amongst Caucasians, and the HFE gene is to blame. A few of the genotypes listed there. Importantly, 1 in 10 people are carriers, and about 1 in 200 people are affected to some degree. As we mentioned previously, the clinical features can often be quite vague and difficult to pin down on history. So patients presenting with weakness, fatigue or tiredness, weight loss, abdominal pain or arthralgia, haemochromatosis should be in your differential diagnosis. Interesting, most people will present between 30 to 60 years of age when they first diagnosed, and menstruation and pregnancy accounts for a delayed presentation in women. Examination-wise, in the early stage of disease is largely non-specific, but if they're getting towards end-stage organ failure, you might see some of the following. We'll go through some of the main complications of haemochromatosis now. So liver disease, you might find hepatomegaly, cirrhosis or cancer in 30% of untreated haemochromatosis. Skin hyperpigmentation is usually a late sign of disease and is caused by iron deposition in the skin. And diabetes, again, is usually seen in advanced disease caused by deposition of iron in the pancreas. And it's a combination of the skin pigmentation and diabetes mellitus that leads to the term bronze diabetes. Arthropathy can be found on radiology involving the MCP joints, PIPs, also the knees, feet and wrists. The reproductive system is involved with hypergonadism causing decreased libido and erectile dysfunction in men, but also amenorrhea in women, which isn't as common, and both are thought to be due to iron deposition in the pituitary gland. Cardiomyopathy is also seen in young patients sometimes, and dilated cardiomyopathy and congestive heart failure being of note. Also, anyone presenting with hair loss or koilonychia, spoon nails, osteopenia or osteoporosis should be investigated for haemochromatosis. We'll now talk about the investigations looking at iron overload. So firstly, to note, the full blood examination and ESR will be normal, and it's iron studies that are going to be the diagnostic aid. So serum ferritin is an acute phase reactant and can be raised due to alcohol, chronic inflammation or liver disease. But if the serum ferritin is high and the transferrin saturation is also high, then haemochromatosis is likely. If that serum transferrin saturation is normal, then it's much less likely. Further investigations may include a liver biopsy, which might be indicated by abnormal liver function tests, any of the clinical signs that we mentioned earlier, and a serum ferritin of over 1,000. By this stage, you probably will have a gastroenterologist involved, certainly to be ordering a ferry scan, essentially an MRI, looking at iron deposition in the liver. And it's thought that this may eventually replace biopsy. Other tests to follow up on end-stage organ disease include echocardiogram for your cardiomyopathies, blood glucose for pancreatic involvement, alpha-fetoprotein and endoscopy looking at more liver disease. Screening is recommended for first and second degree relatives of patients with hereditary haemochromatosis and will involve iron studies and genetic testing on the blood. It'd be a good idea to follow up iron studies regardless of any gene testing results, as different genes can be implicated in iron overload. Patients should also be reminded that their life expectancy is normal as long as the hemochromatosis is picked up prior to some of the end-stage organ disease. Management-wise, as mentioned previously, we'll be getting a gastroenterologist involved early on if there's signs of end-stage disease, but the mainstay of treatment can be commenced in the general practice setting, which revolves around venesection, usually draining about 500 ml of venous blood weekly to start with until the serum iron levels come back to normal. Importantly, this could take about 1 to 2 years to come back down, and the patient could need up to 3 or 4 monthly venesections following to make sure that the serum ferritin remains below 100. Other management strategies may involve chelation therapy, which is a drug that binds free iron in the blood. The main treatment in Australia being desferrioxamine. It's usually reserved for patients who aren't able to tolerate venesection therapy, but it also may occur in patients with severe cardiac disease, anemia or hyperproteinemia, the main reason being it's quite expensive. Dietary considerations are important to talk about with your patients because they're going to ask. Essentially, they can have a normal diet, but to try and avoid vitamin C and reduce their intake of red meat. Alcohol certainly limited to 2 standard drinks a day, and avoiding binges. So in summary, hemochromatosis can present with non-specific symptoms, and it would be a good idea to include iron studies on any part of your general blood testing, or if a patient presents with vague symptoms. For family members with a relative who has hemochromatosis, genetic testing and screening is the norm, and treatment mainstay involving venesection. In our general practice setting, we can monitor end organ damage with the investigations mentioned, but a gastroenterologist is going to be important for helping to treat them. And patients should be reminded that a normal life expectancy can be achieved and that the diet needs close attention as well as alcohol. References for the talk today include Murtaugh's General Practice. There's quite a comprehensive AFP article on hemochromatosis, and also Haemochromatosis Australia website, which has some useful links for general practitioners. Thanks for watching today, and I hope you learnt a bit more about hemochromatosis. If you have any suggestions for future topics, please hit me up on Twitter at ruralflyingdoc. Cheers.